Yeah, thank you. Well, thank you very much, Mr. Chairman. Thank you for all of you for staying here at the late in the afternoon. It's a beautiful day today. And of course, thank you, Dr. Sechkin, for kind invitation to be here with you. I am amongst a distinguished audience, and it would be very hard, especially being the last speaker, to come and summarize. But as I was sitting in the back, and Sarpan, who is managing the Twitter, he said about 300 people are following this meeting. So in addition to you being here, it's about 300 people online following us. To make that one, to incorporate their questions and answers, I would like you to look at these questions: endometriosis, adenomyosis, endosalpingiosis, suture granuloma, and adenocarcinoma. And I'm going to show you this video, and I want you to give me the diagnosis and tell me what you think. You look here, this lady had pain. They told her she had uterine prolapse, so she had uterus sacral ligament pellication. This is a lesion here. As you see it here, when we do the excision, these are the suture material here. These are the margins of the lesion being excised. This is in the posterior cul-de-sac, rectum is here, and this is the suture, and these are the lesions. So going back to the question, tell me which one you think. The one who thinks this is endometriosis, raise your hand. Okay? Adenomyosis, endosalpingiosis, suture granuloma, 2, 3, 4, 5. Cancer. Anybody thinks it's cancer?
Yeah.
No. We have a pathologist here, and this is we had a beautiful pathological presentation by Dr. Ryan. This was adenocarcinoma. So looks could be deceiving. You look here, you had these sutures were placed on the bed of adenocarcinoma. Actually, I did a frozen section when I did the surgery. It came back endometriosis.
It's due to underwater.
It was the final pathology who came back adenocarcinoma. So we cannot really always look at what we see here. And there is an old saying, it says, the eyes do not see what the mind does not see. This is another one. I'd like you to give me diagnosis. The same diagnosis, you look here. We have diffuse ascites, we aspirate the ascites. These are the lesions: cystic lesion, epithelial lesion, ovarian. This is the bowel, and these are all the lesions you look down around here. What do you think these are? Going back to the same questions. Dr. Dan Martin, you can have two diagnoses now. You said you can have two. Which one is?
The C and the E.
C and E, endosalpingiosis and adenocarcinoma. Anybody else? This was actually pure endometriosis and adhesion. Parasitis, everything typical like cancer. The other one, everything typical like suture granuloma. So you have heard these phenomenal talks today, and we have heard a lot of good data. But Sarper said there was no controversy. Everything was following. So I'm going to create a little controversy for us. This is endometriosis, and endometriosis is an enigmatic disease. It's not one disease. It's a process, and it involves any part in the body. Practically, if you look at this slideshow, this is the diaphragm. Practically any part of the body. This is the ureter that almost was choked, and people have lost kidney because of endometriosis. I do work with different companies, but mainly is in education and product development. No financial relationship to my talk and my conflict. You have heard about overview of endometriosis. What I would like to focus is pelvic pain, infertility, malignancy, and see where we would be going in the future. Two things we know for the fact today. Everything else is suggestion. Endometriosis is estrogen dependent progesterone resistant, and it is an inflammatory disorder. This is a fact. The other one, unfortunately, from the time of the first symptom to diagnose it, it takes 8 to 11 years. So we are behind in assessing the endometriosis. You've heard all of this, that could it be retrograde menstruation, coelomic metaplasia, immune dysfunction, environmental triggers. We know for the fact dioxin, we know DES. Patients who have been exposed with DES, 80% they have endometriosis, congenital anomalies. One question, almost all women have retrograde menstruation sometime in their life, but why not all of them have endometriosis? We credit Samson for retrograde menstruation, but actually Samson is the one who opened the eyes for us that if you suspect endometriosis, look for extragenital endometriosis. Historically, 236 years before Samson, Rush described retrograde menstruation. So it goes way back. This is a heart. These are the endometriotic lesion on the pericardium. This is the hemoperitoneum at the time of menstruation. This is the lung. And you see the blood, you see the inflammation on the surface of the lung with the hemorrhage. So spontaneous pneumothorax or cyclic hemoptysia, these are related to the endometriosis from the lung, but actually this is extra tissue of the lung, causes this. And when we resect this portion of the lung, we see that endometriosis from outside is invading the wall of the lung. So in 1967, Kuchner said pneumothorax associated with endometriosis, it could be because of the air going through the fallopian tubes, going through the diaphragmatic hernia. So we have theories all over. If we look at all the symptoms, cyclic pain is the most common symptom associated with endometriosis. Look at the history. All these paintings from the 17th century shows the adolescents, the teenagers, the young women are disabled because of the pain. They were bedridden, either prayer for them or having a house call by the doctor. Why endometriosis causes pain? This slide may look busy, but this is a summary of all the talks you have heard today. Androstenedione is from the adrenal gland. It goes in the tissue because of the aromatase, converts to the tissue estradiol. So why Dr. Einerson said GnRH analog doesn't work? Because GnRH analog suppresses the ovarian estrogen. But the actual tissue produces its own estrogen. Serdar Bulan was here. I mean, he is the one mastermind behind it. So the mechanism of contribution to the pain is activation of the nociceptors in the tissue. The tissue of endometriosis produces estrogen and produces the nerve fiber of their own. Historically, they have used many treatments. In 18th century, they were using materials in the wall, like this is the herbal medicine, this is using the potion or blocking here, but they use bull's gall, opium, or alcohol in the vagina to help the pain. It may sound funny, but bull's gall was androgen, like danazol. Opium blocks the nerve pathway. And alcohol, we use alcohol today to inject, to block for the nerve blocks. So it goes back to the 18th century. The treatment that we use today, it goes way back. Looking at the 20th century, in 1934, this was an ad. So from 18th century to 19th to 20th century, you would see the natural remedies and herb and the massage were used to treat endometriosis. Today we have acupuncture and physiotherapy. So when we look at the treatment, all the summary of all these talks that you have heard, medical therapy, all of them, surgical therapy, removing, excision, Excision, unfortunately, is taken beyond the proper utilization. And then sequential therapy. The success rate for medical, it works for a little bit, then it stops working. The side effects are high. Surgery, there is no cure for endometriosis. There is only cure endometriosis on internet. We don't know what it is. We don't have a cure for it. Surgical excision, in 2 to 5 years, you have 50% recurrent. Why is that? When we look at the infertility, endometriosis could affect all the factors who could contribute to the pregnancy: peritoneal factor, ovarian factor, tubal factor, and endometrial factor. It's a toxic inflammatory organ. In the past, getting pregnant was a treatment for endometriosis. They said if you do not get pregnant, the uterus wanders around the abdomen and causes more trouble. This is an 18th century painting. Before, many thought that the sperm carried a fully formed miniature baby, just needed to cook inside the abdomen of the woman. They thought women had nothing to do with fertilization. It was the sperm. It takes about 200 million sperm to fertilize one egg. That's the contraceptive. So when we talk about endometriosis and treatment, and we cannot suppress them because then it would contradict it. But when you looked at series, and School Crab had a nice meta-analysis and showed that if we just do straight ovarian stimulation, the success rate in the stage 1 to 2 is 15%, 3 to 4 is about 8%. Even if we go directly to IVF, in the best hand, maximum 30% success rate. So getting pregnant directly is not the answer. We had a Cochrane review in 2003 by Jacobson that showed if we go diagnostic laparoscopy versus treatment of endometriosis in a stage 1 to 2, we could actually double the pregnancy outcome. So definitely surgical treatment could improve fertility. Then you heard about adenomyosis. Dr. Isaacson addressed the adenomyosis. This is the summary published by Philip Koenig, Jacques Donnet, Arnaud Battiez. These are the European leaders when it comes to the endometriosis last year. And in last year's review, they said, we therefore suggest that deep endometriosis should be pathologically defined as adenomyosis. So we were talking about adenomyosis involving the wall of the uterus. We are changing the definition of extragenital endometriosis. So as soon as we thought we have an answer, we really are trapped again where we started. In 2011, we had the World Symposium in Endometriosis in Atlanta. 55 leaders of the world, they come. We talked about immunology, mechanical treatment, but the conclusion is at today's expertise, the surgical resection without compromising function of the organ and restoring of the anatomy is the answer. No answer is left behind. We owe a lot with laparoscopy when it comes to the knowledge of endometriosis, not only on treatment, but diagnosis. If you look at even general surgery, urology, the way that we started treating endometriosis by laparoscopy expanded to the other disciplines. It's obvious, instead of having in 18th century a midline incision by Ephraim McDowell, phalansteal incision in 19th century by phalansteal from Kiel, Germany. Now today we have a smaller incision. This is a fact. You were asking about the role of AAGL and endometriosis. AAGL has been in the forefront of treating endometriosis. This is a 1985 postgraduate course, God bless his soul, Carl Levinson. And here is Harry Rich talking about treatment of endometrioma. And then Cameron Nezhat, my brother, at that time treated about video laparoscopic treatment of endometriosis. And that's in AAGL has been a part of this. In 1985, Cameron, my brother, he said, if you do video laser laparoscopy and you can treat a stage 4 endometriosis with good outcome, practically you could do anything. The problem was laparoscopy before that it didn't take off because it was a one man, one eye, one hand procedure. Attaching the video changed the whole operating room to an orchestra, and everybody in the OR became involved. Now we had devices developed, we had energy came, we had laser, monopolar, we have scissors, but the principle was the same. This is the bladder, this is pelvic sidewall, this is the uterus. You can vaporize it, you can excise it. The whole thing is not to damage a tissue, just eliminate the pathology. Excision, vaporization, all of them would work. This is a 1991 report of bladder endometriosis. This is a lesion cystoscopy inside the bladder. The reason I show you this because we reported 16 cases of bladder endometriosis. One of them was adenocarcinosarcoma. It was one of them. So you have to, when you see a lesion like this, it is important to remove it. Any device is fine. This video looks old because it is old. But the lesion is everted, excised. We could see better. When you see better, you can perform better. We magnify the tissue, approach, see the ureters, see around here, and then the lesion is removed with a healthy margin. Then it was repaired. So this is no-brainer. It's been done for more than 20 years. The most invasive disease could be treated. Now this is the case I'd like you to pay attention, please. This is the right side, left side, this uterus is here. Look at the tiny, tiny spots of endometriosis. This is the uterus. You see, this is what I describe it as miliary type of endometriosis. The small spots all over the abdomen. Now, the knowledge of the anatomy and proper instrumentation are the key factor here. A dull scissors, chewing, changing it to the sharp scissors, but this is too aggressive of a dissection, makes a hole in the bladder, finish. It's a complication. Call the urologist, all the disease left behind. So certain procedure like these were a setback to the advancement of the minimally invasive surgery. Because something can be done, doesn't necessarily should be done. Laparoscopy didn't take off because if I focus on this here, lack of precision, you are working through the instrument, and poor ergonomic. You had to work in a counterintuitive environment. And that's why the robot came in. The hope for the robot is to bridge the gap between laparotomy and laparoscopy. It didn't come in to replace a good technique of laparoscopic surgery. The company made these things. This is origami, and this is peeling the grape. This is the actual function of the arms. You have more articulation. You can precisely excise the lesion. Do you need it? No. But this is what it's been advocated, that you could decrease the tremor or you could downregulate your movement. That was good. Yeah. To be the best hospital, you had to have the robot, otherwise you're falling behind. Vogue magazine, to be in Vogue, you have to have a robot. They called it Wizards of Oz. So it really, anywhere you look, for each dot, you could see about at least $2 million. The robot has exponentially grown around the country. You say why? I do not know why. I'm going to show you. This is side by side. Let me pause this. This is endometriosis. This is done in 1990. This is a ureter. Just practically shaving the disease with laparoscopy of the ureter. That's the ureter I showed you in the beginning that almost the patient lost a kidney. If this lady had gone to the urologist, they would have done resection and reimplantation. But practically, we have been able to do a precise excision of endometriosis. Dr. Advincula reported to the AAGL position statement, and he said, on endometriosis, Nezhat reference was used. It's a retrospective paper, nothing much to say. Respectfully disagree. Sarper, this is for you. I disagree with him. I'm going to show you. We have done this fine dissection of the ureter for endometriosis. This is the robotic that you can do it. In the experienced hands, you do not need the robot. And actually, today's robot in its form and shape is a setback because you do not have tactile feedback. True, you could do a fine dissection. True, there is no tremor. True, you could use your electrosurgical devices. But this ureter could be easily transected because there is no tactile feedback. So that's why we reported that for endometriosis, today, robot does not have superiority. It is the experience of the surgeon. The drawback of a robot, this is right pelvic sidewall. People say, okay, why the news media? This is lack of knowledge of energy. The robot here not only made a hole here, I want you to watch here. This is a delayed injury. This was recognized, it was managed, but as you go here, this is unrecognized injury to the external iliac artery. So the lack of knowledge of the device, actually robot could cause trouble. That's why you see negative feedback. If you can do something fancy, it's still is the wrong thing to do. Papa said surgeons must progress beyond cutting and sewing. We have to change our thinking about the way we approach medicine. True, we have new energies coming, but everything is focused on endometriosis. We have plasma who works on the blood vessel so precisely. It's not damaging it, but again, it's a surgical mentality. This is the favorite quote by my mentor, Dan Martin. This is from Donna Vogel in 80s, who was working at NIH. She said, endometriosis is a difficult disease to live with and difficult to understand. It's like nailing Jell-O to a tree. It just makes sense. We are here today, we think we are doing something good about endometriosis, but I don't think we are. As Einstein said, we cannot solve our problems with the same thinking we use. I think we can work toward building molecules who could stop growth of endometriosis. So maybe surgery is not a factor, giving toxin or chemotherapy or radiation is not a factor. Maybe we should go towards the gene. So if I summarize all of these, we do know endometriosis affects million women, prevention, diagnosis, and treatment. This is a busy slide, but look here. If we could have targeted therapies, and if we could have non-surgical diagnosis, that would be the future. We are working at Emory, looking at the blood and peritoneal fluid, endometrium, and endometriosis, and we are hoping to find strategies and simple blood tests to see if we could find patients at high risk for endometriosis. I am also working with a collaborative study with Shannon Hawkins at Baylor. We are looking at the microRNA level, and hopefully we could have gene therapy for treatment of endometriosis. And I would like all of you to invite you to AAGL this year in Washington, D.C., which would be the main focus, talking about how we can approach this enigmatic disease when it comes to the prevention, diagnosis, and treatment. And thank you for your attention.
That was an amazing, comprehensive review, articulate review of the literature. We have a 15 minutes for question and answer. 10 minutes.
About cancer, I didn't show because you saw that beautiful, beautiful talk. The only thing, if I may add, when we looked at our series of the patients that FAR actually did a review of all the patients that we did, it was published in Fertility, Sterility, and it's easily accessible. One thing to remember, patients with endometriosis, they have risk of a recurrence for 2.4%, but then if they have been treated for fertility, it becomes 4.2%. So fertility treatment on the patients with endometriosis could increase the risk of ovarian cancer. That's one thing I would like to add.
Hi, I just have a quick question. If endometriosis is not a benign disease, then would it be considered malignant? And why is it not considered cancerous, since cancer is a disease that is manifest by multitudes of different disorders involved with it, and it has the ability to have uncontrolled growth cell that goes from one part of the body to the other. It sounds as if you're describing endometriosis, so why is not endometriosis cancer?
I would probably pass this answer to the pathologist, but one thing I can say, we are looking at endometriosis as one thing. It's not one thing. Endometriosis is a process. Remember, adenomyosis, the definition is changing. We have nerve production, estrogen production, some are black, some are fibrotic. It's a process. Some of them are at higher risk for progress to cancer than the other. But go ahead, please.
When me, from the eye of a pathologist, I could say even in ectopic endometrium, we have proliferation and then menstruation, so it proliferates every month during reproductive period. So no matter it's in outside of the uterus, outside of the endometrial cavity, it may proliferate. And we had rather call it implantation rather than metastasis. So totally it's a different from the properties of a neoplastic process.
If you read Fertility, Sterility, this issue, it came up a week ago. There are 3 good articles it would relate to it. One is from Serdar Bulan and Aski Fazal Abbas, that they are working on the baboons. They create endometriosis in the baboons, and then they use aromatase inhibitor, and 2 conclusions. When you look at, especially has beautiful slides, you can look at it. The patients or the baboons who were not on the aromatase inhibitor, they had 40% progress of the disease. The patients who were put on the aromatase inhibitors, not only the disease, 43% they had atrophy and disappearance. You could see that they were on the histology, it was lack of stroma. So completely changed the pathological aspect and histological aspect of the disease. That's number one. So Sardar, he's not here, but definitely his study on aromatase inhibitor deserves the credit. It blocks the cytochrome P450. Number 2 paper, it is by Jacques Donnet, that they take a piece of the uterus of the baboon and they implant it in the cul-de-sac. And they create nodular endometriosis, like infiltrative endometriosis. And then you look at it, it is myometrium, endometrium, and the transformation zone. So that may answer your question. Hopefully the baboon studies would open the eyes for our future diagnosis of and knowing more about endometriosis.
Gina,
Yes, sir.
you mentioned about endometriosis is a process, and Dr. S just mentioned about endometriosis progress, proliferated, and it could go all the way to cancer. Also, there's high incidence of it. And I'm always puzzled by the biological behavior and actual patient symptomatic too. The superficial endometriosis and the deep infiltrating endometriosis seems to me it's I don't know, it's the same disease with two different expression, or is it totally two different disease? I want your comment on that.
Great question. And the best way to answer that question is the ureter. We looked at the histological evaluation on the patients with endometriosis of the ureter. Endometriosis of the ureter, if it is external, it could explain retrograde menstruation. But if the endometriosis grows from the inside the urethra, intrinsic ureteral endometriosis definitely goes from the coelomic metaplasia. But extrinsic could be iatrogenic or could be menstrually produced. The bladder endometriosis that I showed you, true, it had adhesions between the uterus and the peritoneum, but the actual fungating lesion was inside the mucosa, and it started from it. That's not retrograde menstruation. That's the coelomic metaplasia.
So are you talking about superficial endometriosis, the origin of the superficial endometriosis and the deep infiltrating endometriosis are different?
For sure.
So it's a two different disease, or the same disease with two different
I told you in the
phenotype
beginning,
or
our
expression.
knowledge is limited. We are looking at endometriosis as one disease. I look at endometriosis as a process. In the earliest stages, cancer was a post-mortem diagnosis. People would die, they would do it, they would find all these lesions. Now we have different type of cancer. We have endometrial cancer, fallopian tube cancer. Endometriosis will be just like this one day. We will have different type of the glandular stromal pattern of endometriosis. I should not answer that question. The pathologist, the professor of pathology should answer that question. But that is the future.
I think we're running late, and we can carry on the discussion in the next years.
Thank you very much.
Thank you.